Yes, before we'll jump into our presentation, I just want to introduce ourselves. So I'm Patrick, senior at San Ramon Valley High School, and
I'm Aayaan. I'm a sophomore at Archbishop
I'm
High
Vineet.
School.
I'm a junior at Prospect High School.
I'm Hiresh, and I'm a sophomore at Mission San Jose.
and our last member is Nishad, who is unable to attend today, and we're in Dr. Mui's computer science group. So the basis for our research is, so imagine you have a hospital that is short on resources, is strained on resources, and for some reason, maybe it's because last month they didn't receive the funding, or for whatever reason, they're missing staff, medical equipment, medical supplies, and medication. And so what they need to do is they rely on a system called hospital triaging, which is a semi-automated like algorithm that kind of classifies and prioritizes patients of different severity to kind of order them in their admission or discharge from the hospital. So how these systems work is that they take into consideration several factors, of which a few are ESI, which is Emergency Severity Index, which is the quantification of how hospitals will rank patients based on their need and how critical their condition is. Secondly, this is not in order, but gender, employment status, insurance status, race, ethnicity. Also not displayed is marriage status and first language and the primary language. And our research is divided into two tasks, and we want to focus on investigating whether or not ESI, or how patients are prioritized in the hospital triaging system, is any way related to the other secondary provided factors of like gender, employment status, insurance status, etc. So our work was divided into two parts, the first of which was a classification task, in which we used a random forest to classify patients into two categories. The first one being their admission into the hospital, and the second one being their discharge. And the second portion of our research was the data analysis, in which we used a software program called SHAP values, which is a transparency algorithm that reveals the most important factors that went into the hospital triaging system. And we obtain our data from a Kaggle website. And to brief our major findings, insurance status seemed to have the largest impact on the hospital triaging system. And additionally, another major finding was that a patient's ethnicity was more important for patients under the age of 40 than for patients over the age of 40. And one other factor that we took into consideration was whether or not the patient had their first language as English, and whether or not that had any impact on their admission or discharge from the hospital. So with that, I'll hand it over to Vineet.
So hospital triaging and the selectivity of certain patients has been increasingly prominent in today's world, especially with the pandemic in 2020, which is still ongoing to this day. This implicit bias has led to certain patients or ethnic groups being prioritized over other patients. In fact, over 80% of all hospitals in the US utilize ESI, or Emergency Severity Index, as Patrick mentioned earlier, as a tool utilized to determine a patient's need for care. These factors account for both patient acuity and medical resource needs. From our literature review, we found that the minorities generally receive higher ESI levels compared to those of other ethnicities, such as Caucasians, and thus this leads to significantly unfair treatment despite similar symptoms that may occur amongst all patients. Our objective is to identify this bias in the triage setting and help find methods on mitigating this bias. As mentioned earlier, ethnicity, insurance status, and one's first language had major impacts on admission and discharge.
Okay, I'll explain the methods that we took to actually conduct our research. So the first step was basically gathering the data and pre-processing our data. We obtained our data from a Kaggle dataset, and our Kaggle dataset contained a bunch of a bunch of patients and a numerous amount of features associated with each patient. If I remember correctly, there are about 972 features associated with each patient. But we only wanted to focus on a few, such as ESI, age, gender, etc. So our first step was to actually narrow down our data set to these select columns. And the result of that was the data set, which you see on the right. So the second step was to actually apply a model to this data set. We chose random forest because it's a pretty popular model and it generally performs well for classification tasks. Random forests use a number of decision trees that is specified by the programmer, and it takes a prediction from each of those decision trees and conducts a majority vote. The essential principle behind a random forest is that there is wisdom in the masses. But if you know anything about neural networks, you'll know that they're generally treated as a black box. You put data in and you get data out, but you don't really know what's going on in between. But for the purpose of our research, we wanted to know what the model was thinking and how it basically ranked certain features. So the algorithm that we used to do this was called SHAP values. SHAP values, as Patrick mentioned, is a transparency algorithm that performs computations to tell us which features the model thinks are most important. It basically increases the model's transparency and allows the programmer to know what the model is thinking. And with that, I'll pass it to Hiresh to discuss results.
So I'll be talking about the results that we got using the SHAP values. So in our results, the red indicates patients that were admitted and how much each factor plays on a bias in their admission. To get these graphs, we split our data into sections and created a chart using the transparency algorithm, which Vineet talked about, which is the SHAP algorithm, which is the SHAP values. In our results for male and female data, we found that a male's age had a greater impact on admission into hospitals compared to a female's age, as you can see in the male and female column. And if you look at the full-time employment patients and unemployment patients, you can see that the insurance status is more important for the unemployed patients compared to the fully employed patients. And we also saw a bias in the insurance status, as for patients with a private insurance, the insurance status had a much higher effect of admission than for patients with Medicare. Another bias that we saw was with patients whose main language was not English. We saw that for these patients, ethnicity mattered a lot more for admission into a hospital. And could you switch the slide? Okay, so this is our discussion in future works. So in the future, we plan to do more analysis on specific diseases that have patient triage bias. We can also do this for COVID or any other new diseases that come up. And we also want to get data sets from other local hospitals so that we can get local data that is specific to city. And we want to get more recent data if that is possible. We want to determine the impact of other attributes, including but not limited to race, the political party, ethnicity, and anything else that we think of in the future. And then I'll pass it off to Patrick.
Right. So to brief over some of the most important references that we use throughout this process, these are references, and I'll move on to conclusion.
So in conclusion, hospital disposition includes how a patient is likely to be directed or advised in the hospital setting. From our data, we found severe correlations among several of our tested factors of a patient's sex, employment status, insurance status, and age, and their disposition within hospital theater. With regards to sex, the feature of one's gender proved to be greater in weight in determining a male patient's hospital disposition than that of a female patient. These values can be interpreted as the hospital triage algorithm being slightly more biased in favor of providing male patients with healthcare over female patients. Another disparity, say, lay in a patient's employment status. And bias and discrimination have been increasingly prevalent in today's world, and the medical field is no exception at all, especially in the context of the COVID-19 surge pandemic. And as mentioned earlier, we use SHAP values to rank feature importance of which we consider sex, insurance status, age, and ESI, which is Emergency Severity Index, to be significant factors within our analysis. We noticed a huge gap in gender bias, with males being given generally higher priority over females. Patients who had a private insurance plan, such as Medicare, Medicaid, CHIP, or even federal, state, or employee health plans, they were generally prioritized against other people, with significant bias taking into play in that context. To further rank our feature importance, we grouped all the data based on their age, of whom who were younger than or older than 40 years of age were split into 2 different categories. From our findings, we found that race had a higher importance for determining their triage placement for patients above 40.
I'd like to say a few acknowledgements. We would like to thank Dr. Mui for all the support and guidance he has given us over this past summer, and our research would have been impossible without him. We would also like to thank ASDRP for hosting us and for providing a platform to perform and present our research.
With that, I think we'd like to open up the platform to questions.